Can we have our next speaker's introduction, please? Thank you. I'm really honored to introduce Dr. Vani Kulhalli, who is an MBBS and MD psychiatry from NIMHANS. She's practicing at Mumbai. I think her experiences are really diverse. I think much needed currently at the present state where we are in with workplace psychiatry. I think the burnout is probably going to be the next pandemic sort of a thing everywhere with all the other things that are happening with layoff and other things. School mental health, pediatric psychiatry. I think, ma'am, I think people like you have been now doing a lot during the COVID as well, including mental well-being of the doctors. Can we have you take us through the next session, please?
So I will be speaking today about the psychosocial aspects of obesity. When we talk about the psychosocial aspects, we have to acknowledge that the psychosocial aspects actually are the basis of the definition of obesity. And therefore, I begin this presentation with examination of what we call as the construct of obesity. Now, what is a construct? Construct is is a term from psychology or sociology, and it is defined as observing natural phenomena, inferring the common features of those observations, and constructing a label for those commonalities or the underlying causes of that phenomenon. So obesity, as we see, is a natural phenomenon, and when we see the person with obesity, then we immediately infer the common features of those observations, such as a large body or certain curvaceous outline, and then we begin to construct label for the commonalities. And now these commonalities are going to vary or the underlying causes. So thus far, we have discussed obesity mainly as a medical or a pathological construct, considering the basic premise that obesity actually implies having a larger than usual body, plus there's also excess fat and some related parameters with excess fat. This is the basis which has never changed. One must also accept that obesity is a psychosocial construct. Who is obese and who is not obese is defined by the psychosocial parameters of those times, which means different things to different people at different times. Thus, psychosocial factors are so important. They arise from these contexts and meanings, and whatever is the psychosocial context, that gives the meaning of the entire term obesity. So what has been happened historically? Historically, right from the prehistoric times, means that places where the archaeological diggings have been done, the kind of figures or the kind of things that they have found there, from then till most recently, about 100 years ago, plumpness was considered as a sign of wealth. It was considered a sign of good health, fertility in women, longevity, strength, and beauty. It also reflected an ability to acquire resources, and hence it was a sign of power. At that time, thinness was associated actually with poverty, sickness, and desperation. Hence, a large body was desired, admired, and a matter of pride. So here we see the picture of the King of England, who is obviously a very large man, but he stands there with pride. Subsequently, the constructs began to change. About 100 years ago, people began to subtly realize that there is an issue with large body size. There were a number of medical studies which began to associate weight with disease and increased mortality. Till in WHO 1948 document was the first time when obesity was included as a health condition in the International Classification of Diseases and Disorders, that is the ICD. Around the same time, media standards also began to change. There was a great accent on androgynous look or the pre-pubertal look. Twiggy was the model who brought this look into great prominence, and they promoted a thin and flat as ideal. So if you see this in Eknoyan's article in the Kidney Diseases Journal, titled as a History of Obesity. Now there was a higher value on athleticism, where people with tall, long-limbed, lean look were considered desirable. This also meant that the social value of a large body has steadily declined. Now, a large body structure is regarded as morbid, ugly, it indicates laziness. It also indicates an illegitimate consumption of scarce resources and a loss of control over eating. Therefore, now a whole industry is dedicated to weight management. Psychological response is the internal response to these social constructs. And now we have a lot of body image disturbances which pursue the ideal of thinness, which results in many types of habits and eating disorders. So, there are also certain subcultures and social norms where obesity is still regarded as normal. For example, there are norms about how one should be at a particular age or stage or profession, or certain cultural norms. These cultural norms are important, especially in the Indian context. In the larger world context, we see that people who are allowed to be obese are the sumo wrestlers. Pregnant women, they're considered to be legitimately obese, and weight gain in preparatory leave for exams. In the community that I work in, a lot of students would think that they are studying well if they gain weight during exams. So now we've come a full circle from a subculture to a large body. And what are we thinking about these large bodies? There is nothing more beautiful than self-confidence, this famous advertisement says, of a plus-sized woman. We come full circle. We are certain people can be healthy despite of their large body. Also, you cannot sort of exclude or shame these people because of psychological disorder, and not a good does not help the person to maintain the weight anyway. Therefore, now we are looking at a movement of inclusivity, where in all professions, including modeling, we are including all body types. We stop fat shaming, because earlier we used to feel that if we fat shame a person, the humiliation would motivate the person to cultivate healthy habits and stop gaining more and more weight. Now we mind our language and we give equal respect people with large body. Body positivity. In body positivity, we encourage people to be proud of the bodies that they have, not to inculcate any kind of shame or any kind of loss of self-respect due to large body size. And the extreme or the encouraging feature is the plus size models who model large body size, and clothes in their sizes are also available. Nutritional education, now we do not say how much is to be eaten, what is to be eaten, but we more probably go for an appropriate nutrition according to our activity levels, so that nutritional education has become more important than eating more or eating less. So we focus more on health and a sense of well-being rather than what size you are and what your health parameters are. So we have now come a full circle. So the psychosocial impact of this full circle is that now obesity is no longer only a medical term. It is also a term that is recognized to have a social context and psychological impact. So once historically we have seen that this whole thing has come a full circle, what are the psychosocial findings with respect to obesity or a large body size? Many associations have been found. For example, large body size has now been associated in various international studies with the low socioeconomic status. In the Western countries, particularly in America, it is found that particular members of the community, such as the African American community, the Hispanic community, as well as Asian communities, suffer more from obesity as compared to the Caucasian people. Educational status. This is particularly important in childhood obesity, they see that when the family educational status is low, then childhood obesity rates are more. Higher the educational status, low is the rates of obesity. What about availability of food and the quality of food available? So initially it was actually said that altogether there was a scarcity of food, and as the society or the community became more and more affluent, food became relatively cheaper. But the cheaper food was not that good in quality. Though it was easily available, the quality was not good in terms that the food that was available was calorie dense, it was mass produced food, and it lacked the balance of nutrients. So it provided more calories but less of nutrition, and that is why in communities where such food is easily available, the obesity rates are higher. What about access to physical activity? Now, access to physical activity is related both to time as well as space constraints. For example, people who have long hours of sedentary work get so exhausted they are not able to do any kind of physical activity, and that creates a time barrier for physical activity. In certain communities, the way the built environment is that there is no access to playgrounds, and there may be also cultural barriers to activity, such as especially in Indian culture, we see that women are not very active. Therefore, when the access to physical activity is low, then the obesity rates increase. Now, the response to stress and boredom. Earlier, the response to stress and boredom would be by going to some art activities, socializing, or people had to work so hard just to get by that they did not have the time to get bored. Now, the reaction to boredom is often to turn towards food, and a lot of time this food is very loaded with calories. It is often what we term as junk food, and that increases the rates of obesity all over. Mental health conditions. People with mental health conditions generally are more vulnerable to episodic emotional turmoil or chronic emotional turmoil, which again causes stress factors in them. And in order to manage their stress, they may start consuming more and more food, because that is the stress management strategy that is easily available and culturally accepted. Therefore, people with mental health conditions are found to have higher rates of obesity. Earlier, it is also true that a lot of medications which were used for treating mental health conditions, through direct effects on the hunger and satiety center, as well as indirect effects like promoting thirst and mouth dryness, these medications used to promote increased weight gain and cause obesity. Now, what about attitudes and conditioning? There is some evidence to show that the attitude towards food as a comforting factor, where even in very early childhood, when the baby cries, the mother rushes to the baby to bottle feed the baby. When the child is a toddler, the mother tries to soothe the child by offering food, and all the kinds of indulgence or sort of show of love is associated with food. Like if the parents are working, they don't have time, they arrange for a lot of fancy foods that the child can take. So food has become a proxy for time, for attention, for love and emotional support, and this causes a kind of conditioning, so that whenever the individual faces some kind of low phase in their life or mood, they turn to food to sort of comfort themselves, and therefore food is being placed at a high level to help emotional comfort, and that leads to increased levels of obesity. Quality of leisure activities is also such that there is a deterioration in the quality of leisure activities in terms of their providing the stimulation, and food is such a thing that it can, through the dopamine receptor, it can provide some kind of stimulation. And when the quality of leisure activities is restricted mainly to using screen time, then sometimes unconscious eating, so you're using the screen and eating simultaneously, that also causes weight gain and increased rates of obesity. What else are we seeing? What happens to people who have high weight? So large bodies, there are social responses. People with large bodies, they face a lot of discrimination. Their discrimination may be verbal or non-verbal. They may face bullying, which comes out as creation of a hostile environment. This hostile environment is created in school, in workplaces, and even in the homes of people with obesity. There is a lot of stereotyping happening. For example, people with obesity are either considered as very slow, very dull, tolerant to all kinds of jokes and pranks, and having a kind of dull and slow outlook towards life. This kind of stereotyping. Also that they have a loss of control for everything. All these together contribute to the stigma against obesity. We healthcare professionals are also responsible to promote this stigma because we misattribute every problem that the person has to obesity. For example, if a person comes to us and says that they are worried about not getting married, then a lot of times my patients have shared with me that the healthcare professionals respond to them that if they lose weight, they might get married. However, that is not the truth in society. Many partners do appreciate having a large spouse. So we do misattribute, or any health problem that we see, sometimes the healthcare professionals also relate that to the presence of obesity. There are certain barriers to access physical built environment. For example, airline seats, a lot of people complain that they cannot access airline because the seats are of a limited variety. Also, the swivel doors which get into certain malls, they prevent them from going. The seats in doctors' cabins, they do not allow the obese person to sit comfortably. So there are a lot of barriers to access because obesity is, even though the rates of obesity are so high, the structures are not modified to accommodate the persons with obesity. What does this lead to as a psychosocial outcome? Every kind of mental health condition is associated with obesity, but the most frequent are depression. More than 50% of persons with obesity suffer from depression, whereas the lifetime rate of depression is more than 100%. Anxiety disorders are very common with people having obesity, and eating disorders are more common in patients having obesity, particularly bulimia nervosa and nighttime eating disorder. Earlier, drug-induced weight problems in mood disorders and schizophrenia were common, but now we have better medications so that these weight problems are not seen so much. So, what is the Indian scenario? I presented to you a lot of studies from the Western countries, but now every paper, ICMR has been studying this phenomenon of obesity for the last 25 years, and every succeeding paper has found an increased prevalence of obesity. At this point of time, in the last 5-6 years, the prevalence is between 10 and 30% among the different age groups, and this is steadily increasing. Women seem to have higher rates of obesity than men, and that is because of cultural factors, where women are encouraged to gain weight during pregnancy. They are encouraged to become less active and after marriage, and post-menopausally, the activity levels go down drastically. Simultaneously, a lot of women acquire daughters-in-law and the elderly status around the menopause time, and they further reduce their activity levels by stopping the withdrawing from housework. So women have higher rates of obesity than men. Unfortunately, in India, what we see is high rates of education and high socioeconomic status is actually related to higher rates of obesity. So whereas in the Western countries, education has helped them to understand the importance of good nutrition and control their obesity, whereas in India, we are still going through the phase where this is working at the level of access to food, and high socioeconomic status is associated with higher levels of obesity. Urban people are more obese than the rural. That is because of less time and less space to engage in activity. And there is an age-related obesity, particularly the abdominal obesity and the central obesity, which increases steadily as the age increases. So this seems to be a factor, but the generalized obesity is one thing which has become more common in pediatric age group. So this is a summary of the different psychosocial factors associated with obesity, both from studies abroad as well as in India. Thank you.
So I think that was a wonderful talk, Dr. Vani, and I think these aspects we usually tend to neglect as doctors, and bringing a psychiatrist into the picture makes a lot of sense. So any questions, Dr. Mathangi, from your side?
I was just thinking, like connecting what Madam said before and this. If I'm looking at society plays a very important role, and also the mindset, like how we need to work at different levels to see that, like what is considered good by the society has been changing, as beautifully Dr. Vani explained. When obese men were considered beautiful or women were considered good, and slowly changing and changing to size zero and other things are now becoming inclusivity as well. I think the pandemic of obesity has to be addressed in a better manner, so that like we are not going to have the lifestyle related disorders more. I think she brought it beautifully with ICMR study coming up for the last 25 years, with increasing in the prevalence of obesity. And even the latest call for, which has come from ICMR, they have also given the one of the thing to be worked on for trust area for research is again being on obesity and NCDs. Thank you so much, madam, for beautifully bringing it.
Thank you.
Vani ma'am is here. Ma'am, can you be on your video as well? So we'll have with the speaker.
My video is switched off by the host, so I'll need their cooperation too.
Okay, fine. Yeah, okay, ma'am. We'll just check with Prachi is also here. We'll just check with Prachi. We have our last.
Can we have her video? The Manish is there, no? Yeah. So okay. Yeah. Yeah, we have her on screen.
Yeah, ma'am.
Okay, now.